meeting of the House Appropriations Subcommittee on Health and Human Services is called to order. Clerk, will you take the roll, please?
Chair Morse,
Here.
Vice Chair Martis.
Here.
Representative Hood. Representative Braybeck. Representative O'Neill. Representative Puri.
Here.
Representative Farhat. Representative Price. Representative Skaggs.
You just missed roll call.
Representative Snyder. Vice Chair Green.
Present.
Representative Bolin.
Here.
Representative Meerman. Representative Kuhn.
Here.
Representative Steele. Madam Chair, you do not have a quorum.
Thank you, Clerk. Welcome today to our day 2 of public testimony. We are happy to welcome members of the public today to be able to weigh in on our 2023-24 budget recommendations. And we have some people on Zoom, and we have some people who've submitted cards. If you're here in person and you would like to testify, please fill out a card for us if you haven't already. And what we'll do is just go through the cards. We'll have you come up. Please make sure you turn on the mic if you're here in person. There's a button that says MIC, and just turn that on. And the members may ask questions, so if they have any follow-up, I'll give them an opportunity to do that as well. And so thank you for being here. And with that, our first speaker is Amy Zagman of the Michigan Council for Maternal and Child Health.
Good morning, Chair Morse, members of the committee and staff. Thank you for giving me the opportunity today to speak briefly about Michigan Council for Maternal and Child Health's support or items that we support in the FY24 budget. The Council is a membership organization. We're comprised of large hospital systems, professional groups, and community entities, and we're celebrating our 40th anniversary this year, really with the idea towards collectively working to support policies that benefit not just one organization, but the board that my board believes will improve the maternal and child health outcomes for all. My comments today are going to focus just on the Healthy Moms, Healthy Babies recommendations that the executive made in the FY24 budget. We certainly look forward to working with you on other parts of the budget that we are engaged with. Michigan has a persistent problem. While our overall infant mortality rate has declined to the best ever rate of 6.2 deaths per 1,000 live births in the state, we have persistent inequities in infant and maternal health outcomes, with preventable deaths and complications in our state much more often for Black and Brown individuals. I did give you just a snapshot of the data that's available with graphs on both severe maternal morbidity and infant mortality rates. It's tucked behind the written comments. In that, I think the most compelling item to see is really that over time, we have not made progress really on the disparity between Black rates for maternal morbidity and infant mortality and the white rates. So we make progress, but we don't narrow that disparity, that gap. 3 items that we're supporting in the FY24 budget that we feel have good evidence to help reduce that disparity are $10 million proposed for centering pregnancy. We've included information about centering pregnancy, but what we know is that group-based prenatal care makes a difference. And group-based prenatal care brings together a cohort of pregnant individuals with similar due dates. They form a group, and together during 2-hour appointments, they receive education on various topics, things like breastfeeding, safe sleep, child safety. They learn about monitoring some of their own health in the prenatal period, things like blood pressure, measuring the fundus, and they also receive time, as you normally would with a nurse practitioner or physician. But it's really if you think about it, easy to understand why group-based prenatal care also has some other inherent value. Bringing together individuals who are going through the same thing at the same time presents an opportunity for supports that may not exist with their family or friends. The best endorsement I can think to share with you about centering real quickly is a quote from a mom in the Henry Ford Health WIN Network program who shared the empowerment of the approach. She says, "I was less scared when I became a mother. I had the necessary tools and resources to not only help myself, but help other mothers I had met as well." We also would support the $10 million for the Michigan Perinatal Quality Collaborative. Almost every state has a perinatal quality collaborative. In Michigan, we've chosen to take a regional approach with our perinatal quality collaboratives. We've shared information with you about where the regions are. They're based on the prosperity regions. And I know because my members participate in their regional perinatal quality collaboratives that the idea of bringing together those who are working in the medical field, those who are working in community settings, those who are working in public health across the perinatal continuum to talk about regional data and regional approaches to addressing issues is so effective. We also support the $10 million proposed for hospital incentives for quality and safety measures. This is tied to the Michigan Alliance for Innovation in Maternal Health. We've shared with you data that's to date about what that initiative has achieved. In Michigan, this is really about implementing safety bundles, and in Michigan, the hospitals that are participating have implemented bundles around obstetric hemorrhage, severe hypertension, and sepsis, some of the leading causes of poor maternal outcomes. This funding would allow hospitals to continue to participate in the MIAM initiative and hopefully incentivize those who thus far have not been able to. There's significant cost to hospitals around training, equipment, data. If you think about it as what it really is a continuous quality improvement process, and without the data, we don't know if it's working. We need hospitals to submit the data, and to abstract that data takes time. We see the participation in the MIAM initiative is really a matter of health equity, and it touches each of your districts. We believe the medical response to an obstetric hemorrhage should be the same in Kalamazoo, in Kalkaska, in Detroit, in Marquette. We want to make sure that any hospital that's birthing in the state of Michigan has the tools they need to respond to any of those crises that might present. So these are just a few of the things that we support in the budget. And what I would say is that these issues around maternal and infant mortality and morbidity and the disturbing racial inequities are not going to be easy to combat. We've seen significant progress in the last few years. The governor's made a high priority of healthy moms, healthy babies. We've seen good bipartisan support for things like extending Medicaid coverage to 12 months postpartum, home visiting, mental health supports. These are three things that we feel are incredibly necessary to help move the system forward and to continue to make progress and hopefully reduce that racial disparity that we see in the numbers.
Thank you, Amy. I have a question.
Yeah.
So I'm sure in the course of your work that you look at what other states are doing. I'm sure other states have issues across the country, we do not have a good maternal death rate. It's frankly embarrassing, especially for as much as we pay for healthcare. Are there, you said a few moments ago that we haven't seen significant progress. So are there states that have seen better progress? And if so, what are some of the highlights of what they're doing that may be making the difference?
I'd love to tell you that there's states that have sort of figured this out. I think many are on the same journey that we are on, trying to reduce racial disparities. What we've seen more is that communities that really make a significant investment and look at providing sort of wraparound care have seen improvements. Communities like Baltimore, communities like Cleveland, California has really been on the cutting edge with regard to the safety initiatives that we talked about. I think they've seen some positives. But on the whole, Representative Morse, I think your point is well taken. This issue and the underlying issues that are part of getting at some of the systemic inequities and the systemic racism, frankly, that is driving this are not unique to Michigan. Other states have moved forward on several of these things that are presented today. They found ways to incentivize insurance companies to pay for things like centering pregnancy. They are providing state support for their perinatal quality collaboratives. They are providing support for their hospital bundles. And so I think, some of those communities that I mentioned, certainly California as a leader in the safety bundles. I can't tell you that there's a perfect ideal state out there that we're shooting to be like, but we're certainly wanting to keep pace and learn together.
And I do have a follow-up on the innovation in maternal health of bundling that you're talking about.
Yes.
Can you go into a little bit more detail about why, I don't know, because it seems to me, to some extent, the hospitalization part is sort of the end point, and when we are not doing enough in the prenatal phase and the perinatal phase, that we are really missing out. So I was trying to wrap my head around why so much of a focus on the hospital. Is it, and it may be it's a part of the fact that we don't, that's not the highest level of reimbursement, for example. Can you just go into a little bit more detail about why you think that's helpful for the system?
Sure. And I want to stress that we think it's just one piece, that there are and should always be a focus on preventive measures, as you mentioned, access to prenatal care, things like centering pregnancy, where we hope that increases the outcomes on the front end. The My Aim piece, and you have information from the Hospital Association and their Keystone Center about what they've been able to achieve thus far, really deals with some of the medical complications that we know result in poor maternal outcomes. Yes, we would hope that by investing in things on the front end, not the least of which is making sure that individuals have access to health care preconception, would help mitigate some of these outcomes. But when we're at that point, when an individual has been admitted and is about to give birth or comes in with maternal complications, we want to know that if they have a hemorrhage, if they're there because they already had severe hypertension or they developed preeclampsia during birth, or because of a C-section or something, they've developed sepsis, we want to know that reaction and that response will be the same in every birthing hospital. So I would say to you, that we don't think that these safety bundles are the end-all be-all. The Hospital Association and other partners who support My Aim are very interested, and we worked very hard on things like the Medicaid extension, and we absolutely think that investments in things like home visiting and other services are important. But we do want that hospital response to be as robust, as adequate, as equitable as it can be. And we want the data to know that's making a difference. And if we don't get it from every hospital, we won't know. And we also want every hospital to participate. And without some sort of incentive, we're in a situation where 60 of the birthing hospitals in the state are participating to some degree, but they're not participating fully, and we're not getting full data back from them. So I don't know if I've helped just to say, I think this is just a piece, but a really important piece.
Thank you so much for being with us today, Amy. Next, we have Edward Webster of the Senior Alliance.
Chair Morse, Chair, Vice Chair Martis, Vice Chair Green, and members of the Appropriations Subcommittee on HHS, good morning. My name is Edward Webster. I'm the Government Relations Assistant with the Senior Alliance, the Area Agency on Aging 1C, which serves Southern and Western Wayne County. Thank you for the opportunity to testify today. I'm going to cover two topics. The first is our caregiver resource centers, and secondly would be the in-pay increase for in-home caregivers. One in four Michiganders identify as a caregiver. Family and informal caregivers are invisible, unpaid workforce, and the single largest provider of long-term care for older adults living at home. We know from multiple studies that when older adults can age in place in their homes, they maintain their independence, their dignity, and they thrive. These caregivers are an essential piece of the health and long-term care systems. In order to provide the highest level of care to Michigan's older adults, unpaid caregivers need assistance. Creating caregiver resource centers will address the urgent need for assisting and supporting caregivers as Michigan's population ages and the paid direct care workforce shrinks. Caregiver resource centers will create a statewide virtual and in-person resource designed to identify, serve, and support caregivers. It will build upon existing range of information assistance, resource referrals, and caregiver services across the Area Agency on Aging network. Create a virtual statewide educator resource center, outreach to caregivers through a statewide campaign, and finally, provide information and assistance, care planning, crisis support, and additional services to help caregivers continue to provide valuable care to their loved ones. The Senior Alliance strongly recommends the subcommittee allocate an investment of $16.8 million for a statewide network for caregiver resource centers. Secondly, increase in paid in-home caregivers. The Senior Alliance fully supports Governor Whitmer's proposal to raise the pay for in-home caregivers by an additional $1.50 an hour, which would reach an aggregate total raise of $3.85 an hour. These workers are vital to the ability of older adults to age in place. We currently have a crisis in Michigan, not just in Michigan, but across the nation, of providing quality in-home caregiver service to our older adult community. This is a crisis, and the Senior Alliance believes that these measures would go a long way to being a solution to these challenges. Thank you for your time, and I'm happy to take any questions.
Seeing no questions, thank you so much, Edward, for being with us today.
Thank you.
Next, we have Melissa Seifert and Lisa Dunn Cooper from AARP Michigan.
Good morning, Madam Chair and members of the committee. I am Melissa Seifert, the Associate State Director for Government Affairs for AARP Michigan. We are a nonprofit, nonpartisan 501c4 social welfare organization that advocates on issues that matter the most to people 50 and over. We also include their families in on that, and a lot of our policies do both. AARP has approximately 1.25 million members here in the state of Michigan. And with me is Lisa Dunn Cooper, our AARP Michigan Manager of Advocacy. We appreciate this opportunity to highlight and offer our support for 5 items, in particular in the proposed fiscal year 2024 Health and Human Services budget. You should have a copy of our testimony as well as our letter of support on these issues before you. There are a lot of issues in the state budget that are important to AARP members and older adults generally, but out of all of those issues, the Health and Human Services budget bill is where we focus a lot of our advocacy attention, because these services are funded in this budget directly impact the extent to which older adults in Michigan can live safely and in good health as they age. And the programs and services in this budget are also essential for supporting family caregivers in Michigan.
Yeah, I think it works to share.
Yeah.
Thank you. Thank you. And as Melissa said, AARP has identified 5 critical needs and opportunities in the Health and Human Services budget to improve the experience of aging in our state. And we describe that more detail in the letter. But briefly, the first one is the establishment of family caregiver resource centers, as you just heard about from our partner organization, Senior Alliance. That is a proposal that stems from AARP's work as part of a multidisciplinary Michigan team over the past 2 years that reviewed successful models from other states to come up with a way to connect more family caregivers with the types of supports and services that can help them care for aging family members in their homes and communities and avoid or delay the need for older adults to have to move into institutional settings because they start to need assistance with what they call activities of daily living. So this Caregiver Resource Center proposal that we're advocating would build on the resources that are already successfully offered through our state's aging network, but it would scale them to reach more family caregivers. The other 4 issues that we urge you to address are all ways to address existing deficiencies in the state's long-term care system. As in past years, AARP urges you to appropriate additional funding to provide services for older adults on wait lists for Meals on Wheels and other in-home, non-Medicaid senior services, the services that are funded in the Administration for Community Living Supports part of the budget. And that is something that you also heard from our partners in the Silver Key Coalition about last Monday. Another item we urge you to expand is access to PACE in our state. PACE is the Programs for All-Inclusive Care for the Elderly. And we are urging you to invest additional funds in PACE to make sure that it is provided to parts of the state where PACE is not yet provided. And specifically, that is the Upper Peninsula and Northern Michigan. Michigan currently has 24 PACE centers, but they only cover certain parts of the state. So that means that PACE is not available to many Michigan residents based on where they live, even though they might otherwise qualify and benefit from those services. Finally, there's another important issue that you may not have heard so much about, but it really came to light for AARP during the COVID pandemic. So Michigan, like every state, has a long-term care ombudsman program. And these state and regional and local ombudsmen advocate on behalf of residents in nursing homes and other licensed long-term care facilities, assisting the residents and their family caregivers with problems and investigating complaints. So as we describe more in the letter, it came to light during the pandemic that Michigan's long-term care ombudsman program has been terribly understaffed, actually for many years. The nationally recommended level for long-term care ombudsman staffing is 1 FTE per 2,000 long-term care beds in a state. But our state's program is currently staffed at 1 FTE for every 5,166 beds. So that's pretty dramatically insufficient. And in fact, a recent review of ombudsman staffing across the states shows that only 3 states in the United States have ombudsman staffing ratios worse than Michigan. So AARP urges you to address that deficiency and increase staffing for the long-term care ombudsman program to bring it to an adequate level for them to protect and serve residents in Michigan nursing homes.
And then finally, the 5th issue we want to raise today is the need to address the direct care workforce shortage in Michigan, which we know you all have heard plenty about. So we want to make sure that those are adequately funded and make sure that people want retention within those positions. Any effort to increase access to long-term care options relies on the availability of direct care workforce to provide these services in home and community-based settings. And Michigan is currently facing a critical shortage of reliable trained direct workers. With that, we will stop, and thank you for your time today. We really do appreciate it, and we're open to answer any questions that you may have.
Seeing no questions, thank you so much for being here this morning.
Would you like to go to someone from Zoom? Sure. I have Sarah Rubino is online.
Next, we're going to call on Sarah Rubino, who's joining us from Zoom. Sarah, please go ahead.
Good morning. Thank you, Chair Morris, and all members of the subcommittee for the opportunity to testify this morning regarding funding for water affordability. I'm representing the Office of the Oakland County Water Resources Commissioner. Our office is responsible for protecting public health and safety through the management of drinking water, sewer, and stormwater systems throughout Oakland County. We perform operations and maintenance for 22 communities. Our office was recently awarded an affordability and planning grant from the state to study the issue of addressing the state's water infrastructure needs across the state. A key finding in our report is that the problem of water affordability is statewide. Our office, like the other approximately 1,500 public water utilities across Michigan, is faced with the challenge of protecting public health through the delivery of safe and reliable services at a cost that our customers can afford. The problem is that the cost of providing these essential services is outpacing many customers' ability to pay. Public water utilities are not-for-profit government entities that are financially reliant on customer rates to provide sufficient funding to properly invest in massive underground infrastructure that supports water and sewer services. If customers cannot afford the cost of these essential services, it jeopardizes the ability to safely operate and maintain the infrastructure for all users that depend on the system. We appreciate that the legislature included $25 million in the supplemental budget to help prevent water shutoffs, and we are encouraged that the governor proposed $40 million for the same purpose, but that's simply not enough. In 2020, the state had an estimated $800 million annual gap in its water and wastewater infrastructure needs. Although some state and federal dollars have recently been deployed to help fray these costs, it doesn't match the amounts needed. That means that most of the burden of that $800 million gap will fall on the shoulders of individual customers. And if they can't afford the costs, the water system infrastructure in place to protect public health and safety is at risk. The funding slated to help eliminate water arrearages is critically important, but paying off past due water bills is only addressing part of the problem and does not deal with how customers will afford the increasing cost of water services moving forward. Our report proposes an income-based affordability program that would provide eligible low-income customers with fixed monthly bills and tiered amounts based upon percentage of federal poverty levels. Our income-based program is modeled after statewide energy assistance programs that have been in place for over 20 years. But unlike energy programs, it lacks a sustainable funding source to cover the gap between the amount that eligible customers can afford to pay and the amount utilities need to safely operate and maintain their water systems. We support the request recently made by the National Resource Defense Council for an additional $185 million of funding to help launch affordability of programs like ours to ensure that all customers can pay for the costs needed to maintain safe and reliable water systems. I'll support written testimony as well. Thank you for your time today.
Thank you so much. We don't have any questions at this time, but we did see there are two other people with you this morning, Sarah Rudy Hobbs or Kelsey Cook. If either of you would like to speak, please go ahead. Okay, sounds like a no. We'll return to the cards in the room. Next, we have Shelley Garcia and Brooke Van Proyen, I'm probably not going to pronounce that right, of DA Blodgett St. John's.
Good morning, Chairperson Morse and committee members. My name is Brooke Van Proyen. I am the Community Engagement and Support Manager for DA Blodgett St. John's, and this is Shelley Garcia, who is the supervisor of our statewide post-adoption program, Parent to Parent. We are here today to ask for continued support of funding for our statewide program, and we are thankful for the bipartisan support that we have received for the past 9 years. Now I'm going to let Shelley speak on behalf of herself and our families.
Hi, thank you for allowing us to speak today. The Adoptive Family Support Network has worked tirelessly to ensure a well-planned statewide expansion of our adoptive parent mentoring services. Our efforts have provided direct support to adoptive families while we also identify and train parent leaders throughout the state of Michigan. Establishing trusting relationships in communities takes time. Adoptive, kinship, and guardianship families often feel isolated and alone in their struggles, leading them to wait to reach out until they're in crisis. Ever-changing agency staff, contracts, eligibility requirements, and community resources exacerbate this problem. What is enduring about the parent-to-parent model is that we focus on training parents to advocate, lead, and support parents in their own local communities. The passion these leaders have to support families throughout the adoption process and long after the agencies have closed their cases cannot be replaced even by the best social work. Other adoptive parents can give hope and courage to adoptive parents who face the very real challenges that come with parenting children who have experienced profound trauma and loss. As an adoptive parent myself, I can attest to the fact that talking to another person who really gets it is one of the most validating things that can happen. There have been many times on my own journey as a foster and adoptive parent that I felt completely alone and a little crazy. I'll never forget the first time that I called AFSN and talked to a staff person and the relief I felt from finally feeling seen and heard. Parents need this kind of hope to continue through the challenges. If our funding were to not be renewed, our Michigan adoptive families will be faced with losing increased access to services and stability of placements. Our goal at AFSN is to keep kids in families. Voices of thousands of families will be lost. We facilitate support groups throughout the state that will be lost. Our lending library will be closed. A lot of services that help maintain kids in families will be lost. I realize there's a lot of money being put towards mental health in the upcoming budget, and I'm super excited about that. However, AFSN is filling some of those gaps for families now. And we know that it takes time to build things, and we want to be here to continue to serve the families. 89% of the families we serve have adopted or fostered from the child welfare system here in Michigan. We've had parents that have said, a quote, "We have benefited greatly from this organization since we became adoptive parents. We received helpful emotional and practical advice when we were backed into a wall. They provided amazing trainings to help us understand trauma, relationships with bio parents, how to best parent kids of a different race, how to meld as a family, and a 6-week parenting class on how to best help kids with a trauma history. We would not be where we are without this organization." AFSN staff are continuing to reach out to existing groups to provide support, training, and technical assistance to leaders to strengthen their efforts while developing new leaders where there is a gap. To date, AFSN has trained 96 volunteer adoptive parent mentors located across Michigan, now equipped with the tools to lead and mentor other parents for the long haul, decreasing the need for costly agency and system intervention. In short, we need more time to continue to empower, educate, and train strong community leaders in all areas of our state so that we can leave behind an army of dedicated adoptive parents. We're asking you here today to please continue to support funding for AFSN Adoptive Parent Mentors in the 2024 Health and Human Services budget. Please allow our Michigan families increased access to support and help us decrease out-of-home placements. I'd like to close with another example of what we do every day by sharing this post from an adoptive parent. "I get nothing from letting you know about AFSN, except for maybe helping another family, like AFSN helped us by connecting us to resources. Our family was over. Our marriage was on the edge of failing. One of our adoptions was on the brink of being a failed adoption. We had lost most of our friends. We were going insane. No doctors, psychiatrists, counselors, teachers, or specialists helped us. 7 years we tried everything. 7 years. No one had given us one single tool to help us. We now have tools. The next morning, when the kids got up, we used those tools. Our lives were changed overnight. Happy to say we're still married. Our adopted daughter is still our daughter. Is our life perfect? Heck no. Do we know how to help our daughter and family? You betcha. I thank you for your time.
I have a question. What percentage of the state, or the state funding makes up what percentage of your budget?
For this program, it is 100% of the budget for
Okay.
this program. And that is what is so intensely scary about the thought of losing this service, being we are the single only statewide provider. So all services are the same, whether you are in the UP, downstate, anywhere in between, the support that is offered the same. There are other services through AFSN where we have tried, we are continuously looking at other funding sources as well through private partnerships and such. For example, in Kent County, we have a contract with Heart of West Michigan United Way. So we are constantly looking at other funding sources to be able to also supplement or provide support. But in order for this to be a statewide resource, that's been the challenge without seeking the funding that we're here to be able to support all families.
Any other questions? Any online?
Yes.
Okay. We do have an online question.
No questions on mine, I'm sorry. Someone
Oh, never mind. Thank you so much for being here today. Appreciate you.
Okay, thank you so much.
And finally in the room, we have Jennifer McCarty, Carrie Steele, and Amy Krug from Genesee Health System.
Good morning, and thank you for your time today to hear from us from Genesee Health System. I'm Jen McCarty. I'm the Chief Operating Officer at Genesee Health System. A little bit about us. We are the community mental health provider for Genesee County, Michigan, and we also provide the safety net services for that county. We provide services to adults and children who have mental health, behavioral health, substance abuse, and intellectual and developmental disabilities. And we also provide safety net services. So safety net services are outside of what would be considered traditional in the Medicaid programming. It's when your community has behavioral health crisis or community-wide crisis. And we really learned a lot about what it means to provide safety net services during the Flint water crisis. We serve annually 12 to 15,000 people per year, and we've been in our community for over 50 years. We're always looking for innovative ways to provide services to the community and innovative ways to provide the best practices for those services in our community. Typically, particularly in Flint, Michigan, you'll find many people, at least half, live above or within federal poverty levels. And in the school districts, it's not uncommon, particularly in Flint, for children to be 80 to 100% of those children are on free or reduced lunch programs. We serve approximately 32% of children of the entire population of what we serve, and we use our unique partnerships in our community to provide services. So in your packet, and we'll also send it again later, you have a proposal from us. We work closely with community partners, in particular on this project, the Greater Flint Mental Health Facilities Board. They're a unique nonprofit organization that assists us with finding funding and helping us to maintain facilities for the purposes of providing the services that we do. So a little bit about this project. We've built a building, we call it the Center for Children's Integrated Services, CCIS for short, is what you'll hear people refer to it as. And this building really came from us recognizing that our community needs a solid, dedicated, trustworthy provider in our community where we can serve the whole person in one place and remove barriers of accessing care. We had 3 separate and distinct programs that we were operating at different facilities throughout Genesee County. It was the Neurodevelopmental Center for Excellence, an autism program, and Child and Family Services program. As you can imagine, families who struggle with transportation, they have trouble getting from one facility to the next, and they may have to see a provider at each one of those places. We've built a facility that's approximately 60,000 square feet. That facility brings all of those services together. We also know that physical health is extremely important for children who have trouble accessing care, and a federally qualified health center is also to be located in that building. So picture a family being able to walk in with one or more children, and you can see your primary care doctor, you can receive your neuropsychological assessments, you can receive your autism services, any behavioral health, psychiatric, or therapy services, all in one location. That facility really was a way for us to build trust with the community. It was centered in an area where there was some horrific blight. Approximately 15 sites were demolished to bring this building forward, and it's built within the heart of a neighborhood where families felt that the only reason, or the only way that they could have safety was to have bars on the windows. We are in the process of changing the way people see that area of town to be a supportive place and to serve as sort of a cornerstone to improve how people feel in that neighborhood. So as you can imagine, a singular facility providing comprehensive care, we know that families need a place, especially following the Flint water crisis, to receive neuropsychological assessments, autism services, case management. We provide outreach services to help bring people in to the services we can offer, and psychiatric and case management care, therapy care. Now, we know that as people come into these services, we can expand the care we can provide with additional funding. This request would help us to pay down the debt that was incurred to build this building. And you'll see in the materials submitted to you, there's a really diverse set of funding sources. We have local funding that we have secured from the C.S. Mott Foundation. We've received federal funding from HRSA to help us with this building project. What's missing is state funding and state support. This would help us to be able to provide more services to more families if we could pay down this debt. Originally in the request was $3 million. Since the pandemic, as I'm sure many of you know, materials and labor have severely gone up, but also so has our request for services. We've seen over 150% increase in our requests for services since 2019, and we've had to add substantial staffing and substantial programming to be able to support these families. To give you a picture of the after effects of the Flint water crisis, picture school districts where almost 100% of the students in that school, in every classroom, those children have been poisoned by lead. They're experiencing physical side effects from that, psychological side effects, and also there is a lack of trust in accessing care. A coordinated facility that can offer the care in one place in a way that people feel is accessible will allow for more people to receive services. As a safety net provider, we want to continue to grow and expand those services, and support from this request would assist us to continue to grow and expand that programming that we can offer. So with that, I'll leave my colleagues if there's anything they would like to add, and then we'll be happy to take any questions from you.
I think Jen did a great job describing. My name is Carrie Steele. I'm Senior Director of Business Operations, and I've been on this project working with our community to build this, and I just would add it's been a very great community effort to make this happen, to meet a need, specifically in Genesee County and specific needs for the children of Flint. So with that, I'll leave it open to questions.
My name is Amy Krug. So I am here with GHS, but I am actually the executive on loan from the Community Foundation of Greater Flint. So I am here representing some of our community partners. So it was important for those community partners to be part of this because it was a way to better deliver services to those families that needed us most. But it was also a way to really bring mental health into the forefront. We've been able to develop an absolutely beautiful building. If Bill Winarski, my partner here, was here, he would say we have a beautiful building in a prominent location, and that is absolutely true. So it is having the impact of improving that neighborhood, but it's also hopefully elevating the position of mental health. We really want families to feel supported and appreciated and walking into a beautiful facility where they're treated with respect and dignity, and it's not something that's dark or shoved in a corner has been really important. So in addition to the CS Mott Foundation, there's been funding support from other local charitable organizations because we, as the philanthropy community, see the value of this project as well.
Well, thank you so much for being here today and presenting. Thank you for your good work in the community. Next, we have James Gallant, who's joining us on Zoom. James, go ahead.
Hello, hello, can you hear me?
Yes, we can hear you, James.
Oh, okay, thank you. Thank you for the opportunity here. My name is James Gallant. I'm with the Marquette County Suicide Prevention Coalition. And I would like to ask you folks to please consider establishing a legal definition of comprehensive mental health services in Michigan. The governor was on TV and was touting here's $100 million for comprehensive mental health services. And at our Marisa Community Wellness Task Force in Marquette, we came up with the idea to get an operational definition of what exactly does that mean from the governor, the director of the department. And in my comment to you, my written comment, is our response from the director of the Department of HHS, Elizabeth Hertel, through Mr. Galvin, the legislative affairs director, and stating that the Michigan Mental Health Code is now considered the standard in all across Michigan for starting in 2023 budget for all these expanded mental health services that's going on. And in the E3 program and on the department's website, it says funds are to be used for comprehensive mental health services. And all of these schools and all of these all across the department, they're doing stuff different for everybody. And to provide equity for everybody, just provide, say, comprehensive mental health services in Michigan equals the Michigan Mental Health Code, including MCL 330.1712, which is the individualized written plan of services. And now in the schools, we have just a plan of services. But now that needs to be expanded to the individualized written plan of services, which covers 9 categories in a person's life. You know, food, shelter, clothing, medical care, transportation, recreation, education, all those things, but also the needs for legal services. And we have like 1.5 million children that are affected by the Office of Friend of the Court. They have a court ordered standard of care where the assessments do not address that. Like the behavioral works program in the schools now is 161 questions, and it's from Drexel University. I spoke to them, but not one of them talks about the legal needs for services in Michigan because they're nationally validated assessment tool. The department requires that. So that can't address any legal issues in any state if you can use it in all the states. And that's one of the requirements. So what we need is a assessment. We need the validated assessment tool, the BH Works program. We have the, there's several: food, shelter, clothing, medical care. But then the second tier would be needs for legal services. People getting stalked and they need PPOs, and then they have children that have these court order standards of care, visitation, parenting time with the family they don't live with. That's a major driver for suicidal behavior in Michigan, is alienating children from their families that they don't live with, and they lose that connectedness, and they end up hopeless, and that's the road to suicide. And so please get with the definition of that, the comprehensive mental health services, and also please establish in the department and with these funds that you're providing, that all these boards and committees and task forces that you're establishing that implement the statutes that you create, they're implemented with different rules. See, you use Mason rules here, but we use Robert's Rules of Order in the community. But it's not in any of these. Like I just started participating with the School Safety and Mental Health Commission, and it says Robert's Rules of Order, but they do it backwards. They start with discussion and not with the motion. that's the different form of government. That's called deliberative democracy. You start with the discussion first, straw poll, and you work up coalition to it. And in Robert's Rules of Order, the authors say that one of the major sources of confusion at meetings is people don't know what they're going to vote on next. And that's a hallmark of Robert's Rules of Order. And in America, you make the motion first, that's the immediately pending question. Therefore, everybody knows what you're talking about. And you have, you know, all of these, all of your different options. You can motion to reconsider, you can motion to amend. But you're supposed to. What I've noticed is the agendas, they're full of discussion and report. Motion to approve the NIC, move on with their set of questions, ends. So people know what they're talking about. That's the semblance of order. And that's missing in Michigan now. And people, the bullying that's going on, it's vicious out there. And it all starts when the chair assigns the floor without a motion pending. And then gets into staff report recommendation. Before you know it, they change the question, and before you know it, they're making a motion for something totally different. It's clear at the Michigan Independent Citizens Redistricting Commission, when the Republican member, they were talking about approving these policies, and then the lady spoke up, and Commissioner Lang, and she said, wait a minute, you started out with a discussion about process, and now you just made a motion to approve a policy. We don't even have a process yet. And that's how they're doing it. It's bullying, and people don't understand what they're going to vote on next. Shenanigans. It's next, and they're going on. And we need to put a stop to it. And that would be to order as the parliamentary authority manual.
So, James, I'm sorry, you're coming in and James.
Secretary Benson.
Sorry. Your audio is not clear, and we also need to maybe bring your comments to a close if you could. Thank you.
Okay, can you hear me again?
Yes.
No? Oh, okay. Yeah, well, in closing, I'd like to say that instructed by Mike Brady, the legal services director of the Michigan Department of State, that you must follow Robert's Rules of Order. The mediation, we're required to follow Robert's Rules of Order, and it should be included when you create these boards and committees, included in there. It requires Robert's Rules of Order right from the start. Thank you very much.
Thank you, James. Next, we have Mary Ellen Howard joining us on Zoom. Mary, go ahead.
Thank you. Good morning. I'm Mary Ellen Howard, a Sister of Mercy and a member of the People's Water Board Coalition. I come before you today to present a request for funding for clean, affordable water in Michigan. PWBC has been advocating for clean, affordable water and sanitation in Michigan since 2008. According to the Alice report of the United Ways of Michigan, 40% of Michigan households do not have income sufficient to cover their basic needs, including paying their water bills. Delinquent water bills often result in the water being shut off, which endangers public health and ultimately endangers life. People's Water Board has come together with other water justice advocates under the leadership of Senator Stephanie Chang to develop a statewide water affordability plan. Under this plan, households with incomes below 200% of federal poverty level would receive a water bill that is less than 3% of their household income. It's a win-win. Michigan families would have access to essential water and sanitation, and municipal water organizations would receive some payment to provide this water, albeit less than their cost. To implement this plan, we are asking this subcommittee to budget a fund under the Department of Health and Human Services to release municipal water or reimburse municipal water organizations for the difference between what they are paid and their actual cost to provide water. On January 26th, the legislature appropriated $25 million for water affordability, and the governor added $40 million in her executive budget. We are requesting that this subcommittee appropriate another $185 million one time to bring the total to $250 million, which would create a statewide water affordability fund, which should last us for 1 or 2 years. During that time, this coalition of organizations will be working with other stakeholders to create a sustainable funding source, which will not require future appropriations. We will ensure that the residents of Michigan will have clean, affordable water, and municipal water organizations will have the income they need to provide that water. Thank you. I did submit a copy of my request with my contact information. Thanks again.
Thank you so much. Yes, we have your paperwork. Next, we call Barry Rubin, who's joining us on Zoom. Barry, the floor is yours.
Good morning. Good morning, Chairman Morse and committee members. I want to thank you for the opportunity to address you this morning. I am allied with Sister Mary Ellen Howard, as well as Sarah Rubino from the WRC and Cindy Roper, who spoke to you last week of the NRDC. My name is Barry Rubin. I'm a member of the People's Water Board Coalition in Detroit, and I have been working with this organization for the past 4 years, primarily to end water shutoffs and to establish water affordability plans where customers pay based on their income. Shutoffs and unaffordable water are major problems in Detroit, Greater Detroit, and throughout Michigan. I'm here today to ask you to add $185 million to your budgetary request. This amount added to the $25 million that the legislature passed in January related to ending shutoffs, plus the $40 million the governor is asking for now, will bring a needed total of $250 million to bear on these on these problems of water for life. The money needs to be used primarily for 3 things. Number 1, to pay off arrearages on water bills throughout the state. I have heard Gary Brown of DWSD, Detroit Water and Sewer Department, estimate the arrearages in their system at $78 million right now, and that's just Detroit. So arrearages alone will cost well over $100 million just to get water utilities and low-income residents of the state back to ground zero. Number 2, to help continue funding the water affordability programs that have been started, like Detroit's Lifeline program and GLEWA's RAP IBP, or income-based plan. They need further startup funds in order for these programs to become fully operational and sustainable. Startup costs include things like software for new billing systems, money for the state and or local agencies to determine eligibility of customers for affordability programs, training of employees in these new programs, not to mention funds for plumbing repairs and conservation measures. Thirdly, to provide funds for startup costs for water utilities across the state to initiate affordability programs. More than 65% of the residents of the state use public water utilities for water and sanitation, and many of those customers are low income. They have low income. In my mind, I believe It makes no sense to only pay off all arrearages in the state and then not put in place programs to prevent low-income residents and water utilities from falling behind again. That's why I respectfully request that this committee add that additional $185 million to what has been appropriated already and what the governor is asking for a grand total of $250 million. We need to make sure that all Michiganders have access to safe, affordable, life-giving water. Thank you.
Any questions? Next, we call Henrietta Ivy on Zoom.
Good morning. Thank you for having me speak on behalf of the Caring Across Generations. My name is Henrietta Ivy. I am a home care professional. I'm a home care advocate and activist for home care workers in the city of Detroit. I am also the founder of Black Women in Home Care Foundation. And what I do is support Black women who do the work of caregiving. And what I'm coming to you today for, you heard some of my colleagues speaking earlier on the shortages of caregiving, the reasons why we have this shortage of caregiving. I'm going to keep it quick and simple to the point. It is frustrating, very frustrating to have to keep going through this same conversation that I've been going through for the last 10 years, asking and demanding for proper wages and benefits for caregivers and the family caregiver sector, as well as the direct care workers. What I'm asking and supporting of is that you continue to appropriate a funding that will support this workforce, which will build up this workforce, take it out of the shortage, put qualified caregivers and family caregivers in the homes of people who need them, such as uncles, aunts, grandmothers, children. We can kill this shortage by appropriating the proper funding in the home health program, giving these workers a proper wage. I do know that the $235 was allocated out. We need an additional $4 to bring that wage up a little bit more, where we could take this shortage out and put these qualified caregivers in these homes and kill the shortage of qualified caregivers to families that need it. I have been doing this work for a very long time. I'm coming upon 11 years of this work and doing this work with everything in my being to make sure there are qualified caregivers in the homes of our elderly and our children and the people that need these services. I created Black Women in Home Care to give the sense of properly knowing that we have qualified women of color that are just doing this work, but it's not being properly paid and have to struggle every day when they go home to realize they don't have enough food. They don't have enough money to pay their bills, and because of the wages. So they go off and try to find work that they can properly do that will suffice their livelihood, leaving thus another gap in qualified caregivers because of pay. So I'm asking this committee to please make sure you adequately fund the home health program and also put that additional $4 in consideration when you talk about this workforce, because the frustration is real, the shortage is real, and having qualified caregivers in the homes of family members and loved ones is real. So I'm really asking this out of frustration and hurt to please consider appropriating adequate funding for the home health program so we can get these workers back into the home, back into with these families, and they are qualified to do so, and they need to be paid for the work that they do. So thank you very much for hearing me out.
Any questions? Oh, thank you so much for being with us today. There are no further questions for you. Next, we're going to call Christine Suave.
Good morning, representatives. Thank you for having us here today and allowing us to speak. My name is Christine Sauve. I lead community engagement and communications at the Michigan Immigrant Rights Center. We are a legal aid nonprofit resource center for Michigan's immigrant communities. Our team represents individual clients in areas such as naturalization and citizenship, relief for survivors of domestic violence, refugees, unaccompanied children, and farm workers. We also advocate to protect the rights of low-income immigrants and their families. We regularly interact with people who are lawfully residing in the United States, but who are harmed by the 5-year waiting period for accessing programs like Medicaid and the Children's Health Insurance Program, or CHIP. So under federal law, lawfully residing immigrants are subject to a 5-year waiting period before accessing a number of programs like Medicaid and CHIP. However, since 2009, through the Immigrant Children's Health Improvement Act, or ICHIA, states have had the option to remove the 5-year waiting period and also receive federal matching funds to do so. And this would help immigrant children and pregnant people who otherwise would qualify for Medicaid or CHIP. Often we find that people who are in the final stages of their years-long immigration process, they incur very hefty bills and debts when they're injured or face illness. The waiting period is especially burdensome for our clients who are currently following all of the steps to lawful immigration status, but they may not have work authorization yet. Part of that is due to very long wait times at the federal level. So many young adults that we serve are victims of child abuse and neglect, and they're on a lawful path towards citizenship, but they currently can't access benefits like Medicaid or CHIP, even while they're facing these very long wait times for a work permit from the federal government. Sometimes the only arrangements that our clients are able to afford are very far away from where they live, and then this raises the overall out-of-pocket costs into hundreds or thousands of dollars. And then this type of debt is especially crushing for young parents who are trying to stay healthy so that they can care for their families. But the good news is that this is entirely preventable. So we especially applaud efforts to eliminate the 5-year waiting period in the fiscal year 24 budget as part of the Healthy Moms, Healthy Babies initiative. This small change at little to no cost to the state would cover up to 4,000 lawfully residing children, allowing the newest Michiganders to grow and thrive. And Merck has watched this issue for several years, and the vast majority of other states have already taken advantage of federal dollars to expand care in this way. And those states know that improved financial stability and access to consistent preventive care benefit everyone in the state. So Merck would also encourage consideration of the related opportunity to secure Medicaid postpartum coverage for the remaining individuals that would be excluded from the full year of coverage in Michigan. So by expanding access to Medicaid and CHIP through the ICHIA option, along with extending Medicaid postpartum coverage through the maternity outpatient medical services or MOMS program, together that would provide much needed coverage and stability and greatly improve the health and well-being of Michigan children and families. So we encourage this subcommittee to eliminate the 5-year waiting period for CHIP and Medicaid, and to continue to look for ways to protect immigrant families in the future as well. And with that, I'll close my comment. Thank you.
Thank you so much for being with us today. Any questions? Okay, thanks again. Next, we have Chris Stawaz on Zoom. Chris, go ahead.
Good morning. Thank you, Madam Chair, and the members of the committee. Madam Chair, it's nice to see you again. We all appreciate you calling special hearings to take testimony on this incredibly important budget for the people in the state of Michigan. My name is Chris Stewaz. I'm Regional Director of Government Affairs for Global Medical Response and American Medical Response. I'm a nationally registered paramedic and have been so for the last 39 years. In Michigan, AMR provides ground ambulance service in Kent and Ottawa counties in West Michigan, including service in the city of Grand Rapids and the surrounding metro area. We also operate Guardian Flight, fixed wing and rotor wing air bases around the state in the Upper Peninsula and Saginaw, providing emergency medical air transport services. I understand today that you've also heard from other providers around the state and from Michigan Association of Ambulance Services about Medicaid reimbursement funding for ambulance transfers. And I'm here today to echo that testimony and offer additional perspectives addressing the executive budget. That budget does not currently make the recommendation that Medicaid reimbursements for ambulance transport match the full Medicare allowable rate. It does recommend an increase to the Medicaid reimbursement based on the Medicare fee schedule released January 1st. As an industry, we're grateful for that, but we would ask that the legislature go further in its support of first responders than the executive budget has recommended. Healthcare is an integrated system that requires all of its moving parts to be functioning well in order for patients to experience the best health outcomes. As ambulance providers, we encounter community members when they need emergency assistance or when they cannot be safely moved from one healthcare setting to another without care during that transportation. Whatever the situation, time and availability are of the essence. A person suffering a heart attack, stroke, or gunshot wound needs immediate care and rapid transportation in order to survive. A person in need of a bed in a long-term care facility also needs a timely and safe mode of transportation to ensure that they get the care they need without another costly overnight stay in a hospital. At AMR, we're always ready to provide these services to our community, but it's gotten significantly more challenging over the last few years. Medicaid reimbursement rates for ambulance transfers in Michigan were actually stagnant for 20 years. When those reimbursement rates were raised to meet Medicare rates, they were not brought into parity with the full allowable Medicare rate, Madam Chair, we respectfully ask that this committee bring the Michigan Medicaid reimbursement rates for ambulance into full parity with the Medicare rate by clearly defining that the Medicaid reimbursement rate should match the full allowable Medicare rate. It is our understanding that the increase for this change would cost approximately $17 million from the state's general fund and would leverage approximately $51 million in federal FMAP dollars. As costs for fuel and labor continue to rise, the statewide risk for ambulance network instability in our healthcare system continues to grow. 2 ambulance providers on the east side of the state have recently closed, both citing reimbursement rates and staffing challenges as the reasons. We and our colleagues have had to continue to struggle to recruit, train, and retain enough talent to serve our neighbors. This is a demanding job, both physically and emotionally, and we need to be able to compensate our first responders at the rate that they deserve so that they can choose to be in this field and have a living wage. Nothing is more important to us than serving our neighbors, and we ask you to help us keep our first responders ready, available, and on the road for Michiganders. Thank you for your time today and for considering aligning the Medicaid reimbursement rate to the full Medicare allowable rate. And I'm happy to answer any questions that anyone may have.
Thank you, Chris. We do have a question from Rep. Martis.
Thank you, Chris. Good to see you again. Thank you for sharing a little bit more about your experience. I'm curious, you referenced a few places in Michigan having their ambulance services shut down, one of which was in Genesee County. I'm curious if you could share a little bit about since you're working from a regional standpoint, a lot of different communities, a lot of different states, what are typically the impacts of ambulance services going away? What are some of the stresses that are put on local medical and local first responder communities? Can you share a little bit about what happens if we don't maybe fix this rate, if we see ambulance services continue to shut down or go other areas? What are some of the impacts that communities see?
Well, thank you for that question. It's a great one. As I mentioned earlier in my testimony, there are actually two pieces to this. There's the emergency side of the ambulance world, and then there's what we call or refer to as the non-emergency side of the ambulance world. With respect to the emergency part, if there are less ambulances available in a particular area, what we have seen and continue to see, not only in Michigan, but across the country, is a higher reliance on what we call mutual aid, using ambulances from other districts, other neighboring communities to come into a community and provide the services that are not available or available at a level that is below what has been experienced in the past because of a lack of staffing. So that puts a resource drain on essentially an entire area rather than just one community. With the non-emergency side, this is actually something that's not in the public eye as much, but we're seeing people that are sitting in hospital beds literally for sometimes hours and days beyond when they should be, because reliable interfacility medical transportation is not available for them to move to either a higher or a lower level of care. And as I mentioned at the beginning, the healthcare system as a whole is a wheel with a number of different cogs in it, and if one of them is missing or not operating properly, the whole thing slows down. So people are losing beds. Hospitals are experiencing additional charges because people are staying overnight beyond what their reasonable stay should be, and most importantly, patients are being kept where they shouldn't be. And that impacts the overall health and patient care that's available to be given to people in Michigan. So this is a critical time and a critical period to be able to strengthen this transportation system and make sure that it's doing what it's supposed to do for people.
Any other questions? Okay, thank you so much, Chris, for presenting today. Appreciate you.
Thank you.
Next, we have a group led by Michelle Massey Barnes. Michelle, you're welcome to join us.
Good morning, Chair Morse and subcommittee members. My name is Michelle Massey Barnes, and I am a parent with lived experience navigating the children's mental health system. I'm also a co-director of a statewide grassroots parent group, Advocates for Mental Health of My Youth. We had a number of parents that weren't able to speak last week, so thank you so much for opening up space so they could come back and speak this week. I wanted to let everyone know who wasn't present last week that we are coming to you as parents of children with SED, or what the state calls severe emotional disturbance. We don't have children with low or moderate mental health or behavioral health needs, although we do want programming for those children as well. Our children are fairly consistently in and out of emergency rooms. They are having difficulties attending school. Parents are often fearing that their children will kill themselves or kill a family member. They have very complex mental health and behavioral health needs. And in fact, you have to have that level of need in order to qualify for SED or the SED waiver that actually explains that without services, children would require hospitalization or institutionalization. As you will hear from our families, we're having a very hard time accessing the services that we need to keep our children out of the hospital. Even when they meet the criteria for hospitalization, we still can't get them into the hospital. So what is happening is we have this collision of systems, often the community mental health system colliding with juvenile justice, colliding with the child welfare system, with the education system, and it's a tangle that is creating more distress for our families and not less. Often, when nothing works, parents are blamed, even as they're left without any support. So as you'll hear in the stories that follow, there are some things that we feel like would help make our situations better. We support MHAM and their request for funding for specialized crisis and psychiatric residential programs for children that can't be stabilized in the home and in the community. Crisis response, so families don't have to call the police to assist with a mental health crisis. We also support MHAM in their request for specialized care. So children with complex needs can have treatment plans that are based on the best practices for their diagnosis. So many of us are getting wraparound services, but they're not being provided in fidelity to the model. We hear about this great program called multi-systemic therapy that's designed to prevent juvenile detention involvement, but we don't know how to access it. It's a DHS service, and community mental health doesn't know how to refer our parents to it to help keep our children out of detention. The post-network adoption services, like we heard about today, ASFN, we wish they could work with more of our families. We think a group like that, and especially that group, could provide crisis training and de-escalation training to our parents that for some reason we are unable to get from community mental health providers. We want to successfully de-escalate crisis at home, but we can't even get safety plans that address the triggers and the needs. We're also asking for a mental health navigator program along with MHAM, so families have help advocating for these services, and that we can all work together to ensure that problems are addressed and corrected. Like the ARC has said, and like so many even here today have said, living wages and competitive pay for direct care workers would help with the staffing shortage. We know that some of our families get told by their staff that they could work more hours, but they're not allowed to, because if they go over 19 hours, their provider has to pay them benefits, and their provider doesn't have funding to pay them benefits. So sometimes there actually are staff, but we can't get them for more hours because of other complications. And lastly, in this area, we are also asking MDHHS to reconsider how they structure the SED waiver and other children's waivers, because if CLS and respite are being authorized as a medically necessary service and they're not being provided, and parents are filling those roles anyway, like other states do, if we pay parents to provide those services, we could take some of the financial burden off of the parents and have the services provided at the same time. It's not an ideal solution, because when you need respite services, you truly do need a break. But anything that we can do to take some of the stress off of the families that are caring for children with severe emotional disturbance would go a long way to making them feel like the system is understanding what their lived experiences are and validating their experiences. I want to now turn it over to the families, unless you have any specific questions, so you can hear more of our lived experiences and the specific challenges that we are facing. Thank you so much.
Thank you, Michelle. Any questions? Next, we're going to have Melissa Reyes.
Yes, my name is Melissa Reyes. I am from Muskegon, Michigan. I am 43 years old. I am a product of the system. I was in foster care by the age of 8. I was adopted at age 11 by a single teacher. I am bilingual. I grew up in the system pretty fast, but I also had mental health services at a young age. So I'm very familiar with therapy and the different benefits of therapy. I was married. I had 2 children. We planned to have a child. My spouse was from Mexico. My child, at the age of 1.5, had complex partial epilepsy and a seizure disorder. Later on, at 3 years old, she was diagnosed with autism. Later on, after that, I worked in the school system for many years. I had multiple jobs and I could not get full-time benefits. And then I later worked for the state of Michigan myself as a caseworker, as an eligibility specialist, and worked that job for almost 10 years with a caseload of over 800. So I'm very, very well knowledgeable in the Medicaid and resources that our state can provide families. Currently, I'm on my I'm off work right now because my children are both medically complex. My daughter is 17 now. She's currently in a residential program after she tried to attack me with a household item. I've had to deal with CPS services myself because of the things that my children have done. I've tried to get them help. I myself had to quit my job. I am also a community health worker and a licensed cosmetologist with multiple careers behind my belt. It has taken me over 6 years after I lost private insurance from the state of Michigan to have my child go to a residential center that teaches ABA therapy to get her the right kind of help that she needs to be in a community place. She is on the SED waiver. I have had several caseworkers dealing with the Health West here in Muskegon area. Even though I have all of this education and all of these resources behind my belt myself, I've had to fight for over 6 years to just now get the kind of treatment that she needs from one of the first centers of its kind in the state of Michigan. It is called the Heartland Autism Center. It is located in Grand Rapids, near to where we live. Before this, about a year ago, Giselle was hallucinating and she was seeing things and she was not herself. I had to have her on multiple medications. It is a full-time job just to manage the medications that my child needs to take daily. I used to transport my child to the Detroit area because there was no one else specialized in our area to control the diagnosis that we had to deal with. And some of the crisis that we have, the hospital stays that she has had, they've had to restrain my child. And yet I've had to deal with services myself because of the violence that my child can go from 0 to 80. Normally my child is a very sweet child, but there are times where she explodes and she wants to hurt people or damage property. And then I have to deal with picking up the pieces myself. And it's not something that any parent should have to face alone. And thankfully that I found our advocacy group that can help guide us when we are having these kind of crisis modes. And that has been life-saving for me. I'm dealing with this as a single parent now. My children have had every opportunity that I could possibly give them. We have never faced homelessness. We have never faced a day where my children did not have access to food or clothing or anything like that. But some of the programs that my child has needed, one of my crisis workers for Health West told the supervisor, if you do not get this mom help with her children, I'm going to quit my job. No one should have to face any of that kind of thing alone. No one. If I'm asking you for help, if I'm saying my child needs additional services, you have funding sitting there that's unused. And my child is in crisis and you can only give me lip service or try to force more paperwork on me when I have years worth of paperwork, years worth of medical reports of what my child actually needs from you. And I am only just now, after 6 years, able to find her a place that only provides up to 30 days worth of a stay for her. That is a disgrace. I have given so much of my time and my mental health to make sure that my children have access to the best quality medical care. I pay over $400 worth of private insurance now, even though I lost my job, lost 3 jobs because my children's medical appointments trump everything else that goes on in my life. There is no reason why we can't navigate the system better, that Health West shouldn't be held accountable for some of the things that are going on with our children's most vulnerable. If I am a smart, educated person and I've had to fight for 6 years for services that my child should have had at the beginning of our dealings with them, then what is happening to children that don't have parents that have the energy to fight, that don't have the energy to even say, you know what, I can't do this today because my child attacked me over a month ago. I still have the scars. And my child is not normally like that. Well, what are you telling? What is the message we are saying to our children? I'm not going to give up on my kids ever. But I'm not going to be sitting here quiet while Health West has sitting on top of funding and they never have enough respite providers. They don't have enough income. My job went from, I was making over $26 an hour with full benefits. I had additional trainings to be a CHW, and I served the seniors of Michigan, and was also one of the only bilingual workers that they had on staff. When I went to work a few days, there was a couple of days where I saved someone else's life because I know another language, and yet I cannot utilize my talents because I am so busy doing damage control with my children's complex medical needs every single day. I have a right to a life too. But right now, my kids are in crisis. There's kids all over Michigan in crisis for mental health. And yet, if it was a child with cancer, they would have no question about paying for their residential stays or their mental health related services or anything like that. You would pay for that. You wouldn't send a child with cancer home. And I'm asking you, please, please consider funding some of these life-changing programs for these children's, the ABA therapy that they need to have. Please consider allocating additional funding for these children that are in constant battle with themselves.
Thank you, Melissa. Thank you so much for your testimony today and for sharing your story with us.
Thank you.
Next, we will call Stephanie Pizor. And we'd ask that you limit your comments to 3 minutes to the best of your ability. Thank you. Stephanie, I'm sorry, we can't hear you. It looks like you've muted yourself, Stephanie. We still can't hear you. No luck. We still can't hear you, Stephanie. Unfortunately, maybe stay on. We're going to go to the next person and maybe we can come back. Natalie Anwar, you're welcome to join us.
Can you hear me?
Yes, we can.
Thank you, Chairperson Moore, for having this meeting and inviting our group to share our stories. After listening to the previous parent, it just kind of hit home just how vast the system needs work. My short story in 3 minutes, and this is going to be hard. I am a single mother of identical triplets with autism. They are 16 years old, and currently neither of my children are in school. I also have 2 other children, one that's grown and out of the house, and then a 14-year-old. So on December 10th, I had what I dreaded the most, the thing that I'm most afraid of all the time that, you know, I'm waking and breathing, and that is having a triple meltdown. Because of one of my children, his name is Jaden, he has extreme OCD, PTSD, severe anxiety, depression, and intermittent explosive disorder. And I'm sorry, it's just a little nerve-wracking. My son's triggers are each other, identical triplets that are triggered by each other, along with technology issues and then also change. So on December 10th, all three of them had a meltdown or explosion, and all three of them landed in the hospital. This is the first time I had all three of my children in a crisis at the same time. The reason why we came into this crisis is because of lack of community living supports or in-home services. And I have to have 24-hour care because of their size and their physical strength and their explosive outbursts. And all three of my children are capable of this. Two of them are most capable or have this most frequently. Aiden was kept in the hospital from December 10th until January 6th. The other two went home on December the 11th, the day after. It was reported by the ABA provider, or the Applied Behavioral Analysis Therapy provider, that if Aiden were discharged, that they were going to terminate my services for my other two children for safety concerns within the home. Aiden was discharged because of having 14 days of good behavior, even though he was so sedated, he could barely keep his head up. During that time, they were seeking placement, but then decided that he didn't meet criteria because of that good behavior for his stay. 2 days later, he was taken back to the hospital for behaviors. ABA services were canceled. With ABA also meant that they were doing the Zoom school, so my son was no longer getting Zoom school, or my other two children, or my other son that was doing Zoom school no longer received Zoom school. Aiden eventually, over some time, became stabilized on some pretty heavy-hitting meds. But Jaden, who is triggered by his brother, continued with his behaviors, and his elopement and OCD behaviors, they increased. And I apologize. Between January 1st and April, today's date, my son Jaden has been in and out of the ER 40 times as of Saturday. And today marks the 41st time he will again go to ER. He left this morning while I'm sitting on the Zoom call waiting for this meeting. And it is his OCD that drives him. 40 different times to the ER. So my waking morning consists of me figuring out at what period he's going to elope, because he cannot be redirected. And he will be brought home via ambulatory services momentarily, which I have to pay out of pocket because it's not covered by the insurance. That's about 8 visits in the last week. 18 of those visits, 21 of the visits that he's made to the ER happened in the month of March. With the warmer weather right now, we are on visit number 7 for April. And the weather is getting warmer. So the weather, when it's cold, it kind of deters him somewhat. I'm following the crisis plan. The crisis plan says try to redirect him, which we try to do, but we can't, because when we do, there's risk of physical assault. We can no longer transport him in the vehicle because he attacks, because he wants to go a certain direction and can't be redirected. He needs a higher level of care. And this has been extremely frustrating on my family. It's been extremely challenging to navigate. Maintaining the supports and services in the home is a challenge because, as many have said, because of the pay rate, not having the training, or simply because they cannot do hands-on, in which case sometimes that may be required just to keep them safe. My son bolts out into the street when he goes on his elopement on his elopement trips. The one thing that's been really disappointing is that every time he goes to the hospital, I got to the point where I stopped asking for crisis services to do psychiatric evaluations. The last couple of times I did ask for psychiatric evaluation. And the reason why I get frustrated is because they're always not meeting criteria. And I'm wondering at what point does it meet criteria if he's a danger to himself, a danger to the community, and the law enforcement are also making phone calls to the state trying to advocate on my behalf in my county where I reside in Meridian Township in the greater Lansing area. We can't get the services because they don't meet criteria because of their severe behaviors and as of right now, we are on several wait lists with placement not being able to maybe the earliest would be September is what I'm hearing. And we're also trying to get on a wait list for the Kennedy Krieger, which is in Maryland. So outside of all the stress and the frustration and not getting the help we need, I now have to face another issue of possibly sending one or more of my children out of the state, far enough away where I will not be able to be part of that treatment program because my sons need treatment. I don't want them being fostered through the juvenile detention center. I want them to be able to get the supports and services right here in our state of Michigan. And there's a lot more I could probably go into, but I'm kind of distracted because I know that the ambulance is going to be arriving anytime now, and I'm going to have to do damage control for when he gets back into the house. And we have to do this again, probably before the day is up. But that is my daily life, sitting here, waiting for the shoe to drop, waiting for him to make his run to the ER. And that's just one child. All three of my children have significant needs. And then I have my younger 14-year-old son who needs me just as much as the other ones, but who's always taken the back burner to his triplet brothers. So I am imploring you to allocate those resources to be able to help our children here in the state of Michigan stay with their families, get the supports and services that they need, because they definitely can thrive with the right supports and services. Thank you.
Thank you, Natalie. Any questions? Okay, thank you, Natalie. There's no questions. Thanks for sharing your story. Next, we have Molly Bonter.
Hi, my name is Molly Bonter. I'm from Ottawa County. Our daughter, who's currently 14, has struggled with mental health since 2020 and has been a patient at all different types of mental health facilities. She's had numerous 30-plus day stays at the ER waiting for an inpatient bed. She's been inpatient a couple times. However, she's no longer accepted at inpatient centers due to her aggressive behavior. She has had residential out of state in Georgia. And most recently, she's been at Hawthorne Center in Novi. She has spent over 80% of her day since 2020 in some sort of hospital setting. She spent 11 months at Hawthorne from March 2022 to February 2023 when they discharged her against our wishes. We knew she wasn't ready to be safe at home. She was home for 11 days before my husband caught her attempting to hang herself from her ceiling fan in her bedroom. She bragged to the first responders and the ER staff that this was her plan prior to discharge, and she was so proud she tricked the doctors into discharging her home, even though she wasn't ready. While we worked with emergency staff and Ottawa CMH to get her readmitted to Hawthorne, a supervisor from Ottawa CMH told us that when people are this determined to commit suicide, they will usually succeed eventually. Are we supposed to quit fighting to save our daughter's life and give up because CMH says our daughter will eventually succeed regardless of what we do or the services they provide? Once we did succeed at getting her back admitted to Hawthorne, we were told by the psychiatrist there that families in our situation usually end up with three options moving forward. One, the child's discharged home with a safety plan, which they failed to provide at her last discharge. Two, parents temporarily terminate parental rights to get the child admitted to a state residential facility. Or three, parents permanently terminate parental rights to get the child admitted to a state residential facility. So according to CMH and Hawthorne, our only choices are to accept our child will succeed at suicide someday, or to abandon her back into the foster care system and terminate our parental rights to her to get her placement she needs in a residential facility. In either option, we lose our daughter. Parents need options, affordable options, to get residential placement in the state of Michigan without being forced to give up our rights and make our kids wards of the state. Thank you for your time.
Any questions for Molly? Molly, thank you for sharing your story. Next, we have David Horian.
Good morning, Honorable Chair Morse and members of the committee. My name is David Horian, and I'm from Berry County. I'm sorry, did I just get unmuted? Good morning, again, Chairman Morse and members of the committee. My name is David Horian from Berry County. I'm coming to you to talk today about my son, who is currently 11, but who's been in therapy since he was 2. He currently has diagnosis where he's on the autism spectrum disorder. He has a major depressive disorder and he has a generalized anxiety disorder. These diagnoses were given to us by the Hawthorne Center, where my son stayed for 4 months upon his discharge last January. As I said, he's been receiving therapy since he was 2. Because of his complex needs, we are not able to get him the treatment that he needs because of his you can't treat autism and depression and anxiety all the same way. They take different forms of treatments, and we're having a hard time getting all of those treatments at the same time for him. Since 2020, he has been hospitalized in the University of Michigan C.S. Mott Children's Hospital twice. He's been hospitalized in Michiana Behavioral Health down in Plymouth, Indiana twice. He's been at Harbor Oaks once. He has spent 6 weeks waiting for a bed in Hawthorne, not Hawthorne, I'm sorry, 6 months in a bed at the Helen DeVos Children's Center, and following up with a placement to the Hawthorne Center, where he spent a little over 4 months. He went into Hawthorne in September. In November, they told us what the criteria for discharge was. In December, they wanted to discharge him before Christmas, even though he had not met those criteria for safety and stability. And they said that he would never meet those criteria. They didn't know what to do with him, so they wanted to send him home. I may need to inform you that the Hawthorne Center is the only state-run juvenile mental health facility in Michigan for long-term treatment. We cannot get residential treatment, even though that's what's needed, and everyone agrees that it's needed. The law enforcement, therapists, psychiatrists, but agree that it's needed, but we can't get it because he is not a part of the juvenile justice system, and he's not part of the MDHHS system, and CMH cannot make placements into facilities. So we're not able to get him the help that he needs because he's not abused and he's not in the criminal justice system. So that's the current issue we have. So funding for these specialized crisis and psychiatric residential programs would be so pivotal for someone like Dylan, because that's what he needs and that's what he can't get. Additionally, I also want to mention the crisis response issue. One of the first things we're always told, part of the quote unquote safety plan, I use that term loosely, from Hawthorne, was that we were to call the CMH crisis line if there's a problem. Well, just since last Wednesday, we have had 8 major incidents, including him getting a knife twice on Friday before I could lock them all up. Every knife in my house is locked up, by the way, now. And he threatened to kill his dog, threatened to kill himself, and he was threatening to kill me. I called the CMH crisis line and went through the dispatch and was told that someone would call me back promptly. It didn't happen for over 20 minutes. I realized that 20 minutes may not seem long, but when you're in the middle of a crisis, 20 minutes is a lifetime. I ended up having to call the police because anytime I tried to get near my son to get him into a safe place, he would kick and fight and try to throw whatever he could get his hands on at me, including chairs, tables, anything he could get. So we need better crisis response for families so we don't have to call the police. The police really couldn't do anything short of taking him back to the hospital where we would resume another extended stay and be denied program after program. We've been denied access to the DART program, for example, out of Grand Rapids because he's too aggressive. Hawthorne Center doesn't want him because he's too aggressive, and the same with all the other facilities. We do have wraparound services because Dylan is part of the SED waiver. But the problem is even wraparound does not seem to know what services are available. Quite often I find stuff on Google and contact wraparound, hey, can we look into equine therapy? And they research, oh yeah, let's do that. Here we go. Here's what you need to do. But a mental health navigator who knows what services are available to children could help us, again, get the services that kids need that we don't know exist, and even wraparound may not know exists. I'm sorry, it's been quite a ride for the past 5 days. But I think that gives you the gist of what's going on right now. Basically, we're pending a hospital stay again if these behaviors continue, because we're not getting the services we need. Additionally, we do receive CLS support, but they can't even fill those hours. We're authorized 19 hours a day, 7 days a week, and we haven't had CLS between last Wednesday, and we finally had a CLS worker come in at 11:30 last night. So during all those crises, we were on our own. If you have any questions, I'll be happy to answer them. But yeah, it's been a lot going on.
Well, thank you for your testimony today, David. Are there any questions? Thank you so much for sharing your story with us and for your recommendations. Next, we have Trina Toko. Trina, are you with us? All right, next we're going to try and go back to Stephanie, who was having technical issues. We'll try again. Stephanie, can you join us? Unfortunately, we still can't hear you. Stephanie, I guess I would suggest that you can forward your testimony. You can type it up and email it to us if you're interested. Okay, Representative Steele, I understand you have some comments to share. Go ahead.
Thank you, Chair. I am a little mobile, so bear with me if you would. I just have a general comment about the budget process and just being new of these programs fit into the actual budget, and about the overlapping of the different programs between Medicaid, Medicare, mental health, food banks, and just looking for maybe some more oversight and maybe some transparency and accountability in some of these programs to see if I can have a better visual of this big, massive budget and how it fits together. So I was probably looking for more like of a workshop type of a budgeting process. And I'm hoping that as we move forward, we can see some of that, how these programs directly fit into the budget and their overlapping and their transparency, and just to move forward as a better vision for Michigan. So just a general comment. Thank you.
Thank you, Representative. Any other questions, comments from the members? Okay, we did have some additional written testimony that we just wanted to note. So we had from the Nurse Family Partnership, written testimony from Tiffany Bukowski. We have a number of written testimonies regarding traumatic brain injuries, including Monica Van Acter from Resilier Neuro. The Michigan Brain Injury Provider Council by Tom Judd, Executive Director. Special Tree Brain and Spinal Cord Rehab, Joseph C. Reichert, Chairman. Origami Rehabilitation, Tammy Hanna, President and CEO. Hope Network from Margaret Crows, EVP and Executive Director. And they are all advocating for funding from our budget to ensure that people get appropriate health care for their traumatic brain injuries. We also had from the Michigan Academy of Family Physicians a request for Medicaid primary care payment rate increase. I'm sorry, we have an additional for the Brain Injury Services Program, Neurorestorative, Renisha Carter, Executive Director. We have another traumatic brain injury letter from Matthew and Suzanne McMichael from the Lighthouse Neurological Rehab Center, again asking for additional services for the traumatic brain injury survivors. We have from Randy Block support for the People's Water Board testimony earlier regarding water affordability. And we have a request from Camelia Bright for additional workers for DHHS services. We're going to go at ease for call of chair.
There's transparency, oversight, or any
Silvio Orduno, is that you joining us by telephone? Call this meeting back into order. Sylvia tried to get in touch with us by phone. She wasn't able to make it through, so we'll just ask that she provide us written testimony, and we'll have that available for the members. Rep. Green moves to excuse absent members. Hearing no objection, absent members are excused. Seeing no further business before this committee today, this meeting is adjourned.